Good afternoon, everyone, to this very rainy day in Thursday in May 2022. Welcome to the Commission on Excellence and Innovation, to be now referred to as the CEIH Improvement Showcase. This is the last in Series 9 for May. So welcome. I am Tina Harden, Executive Director of Clinical Informatics in the CEIH. We, first of all, particularly given it's National Sorry Day and also leading into Reconciliation Week, very important that we acknowledge that the land that certainly I meet on today is the traditional lands of the Kaurna people, and that we respect their spiritual relationships with their country. We also acknowledge the Kaurna people as the custodians of the Adelaide region, and that their cultural and heritage beliefs are still as important to the living Kaurna people today. I welcome anyone who is not on Kaurna lands to please feel welcome to pop where you are into the chat and let us all know what lands you are attending this showcase on today. Well, for those that are new to the CEIH, our vision statement is together let's create better healthcare for South Australians. We were formed in 2019 and we continue to be a lead agency driving innovation in healthcare in South Australia. Our key focus is really doing things like this, bringing people together, bringing consumers, clinicians, industry, researchers into together to collaborate, share ideas and see where we can learn from each other. And so related to that, what if the big idea was connecting the small ideas? And so really that's the essence of this showcase series and why we put on this event every Thursday. It's all about South Australia and how people across the state can come together. The Improvement Showcase series is every Thursday at 1 o'clock and online whenever. So just a reminder that this is being recorded, and at the end of the recording, we will make these available through our website and also through YouTube. And we have about 20 minutes of presentation from our fantastic guests today, and then we stop recording and open it up to a nice frank and fearless Q&A session, which I'm sure they will love. So we encourage you, if you've got a story to tell, that you've got something that you've learned and really think would be valuable for other people within South Australia to you know, maybe not repeat the same mistakes or to try something similar within your own environment. Come together, share your ideas, see who you can connect with, and really build our strong South Australian community of collaboration. So we're really passionate about that. Or if you don't have a story to tell and would like to know more about something, please get in touch, ceih@sa.gov.au, and we'll see if we can build a theme around that for you. Click harder, there we go. Oh, sorry, there we go. So Series 9 has been about improvements enabled by technology. We kicked off the series with a session in May, presented by Mark Chilvers and Dr. Michael Bradley, all about how they deployed a telehealth triage service for dental health in response to COVID and beyond. On the 19th of May, we were lucky to have Professor Maria Macready's doing a presentation for us around omega-3 screening and treat program in early pregnancy. And today we are very privileged to welcome Tom Beatty, Quality and Risk Manager for Clinical Governance Unit in Sarlan, and Simon Windsor, the Manager of Research and Ethics for the Office for Research in Sarlan. So really thrilled to have you guys present to us today. I look forward to hearing your talk on bring your own device, challenges for consumers and the health service. I will stop sharing and over to you.
Thank you very much, Tina. Yeah, really appreciate the invitation to speak to everyone today. And yeah, thanks Lee and the Commission for organising these series of events, which I think are a really important way to share experiences we've all had. So the theme that we've got is improvement enabled by technology, and the story we've got today is around bring your own device, challenges for consumers and the health service. And it's specifically looking at the experience we had around deployment of a self-registration, self-screening tool at the COVID clinic at Flinders Medical Centre. So a little insight of the team that sort of delivered this innovation. Myself, Simon Windsor, Manager of Research, Governance and Ethics. Tom here, Quality and Risk Manager, Clinical Governance. Di Taylor, the Director of Clinical Governance. We had Dylan Medan in the Office Chief Medical Information Officer, who now is the Director of Women's and Children's here at Sarlan. The Executive Director of Research Strategy here at Sarlan, Professor Andrew Burston, he was the Executive Sponsor. And then we had a range of partners through the Flinders Coronavirus Collective. That was FORCE, and that was around a virtual registry and biobank with Professor Claire Roberts, Professor Derek Chu, and Shalima Marks and Erin Morton, their team, and then Royal Melbourne Hospital. We worked with them around the interface. So that was Dr. Mark Dutch and Shalini there as well. So bit of context for everyone. Southern Adelaide Local Health Network has a strategic direction map, which was launched in September 2019, and there's 4 pillars to that. Firstly, it's our clinical services and the sort of ambition we have to provide clinical excellence to the community. And then secondly, it's our consumers. So how we work with our consumers. And then third pillar, we've got our relationships. So the different types of relationships that we can form and optimize as a health service. And then the 4th pillar, which is really important, is our research. So that's how do we cultivate an evidence-based care environment, and what are the drivers for our new opportunities for staff and the community as well. So the concept around our research direction, which was launched September 2021, is that healthcare facilities that do research deliver high quality care and have better patient outcomes and are more efficient. And we all know the demand on health services nationally and internationally. We've got further evidence here that there suggests there is an association between engagement of individuals and healthcare organisations in research and improvements in healthcare performance. And that's a bit of the story that we're going to talk about today. So the research strategy that we've got here at Sarlan, we're looking at effectively inquiry, and we've got a bit of a tagline below the slide here: be inspired, ask questions, see opportunities, think creatively. So the idea is for everyone in the organisation to know where they are and where they want to be in these 4 fields of inquiry, strengthening research culture, and improving patient outcomes. So the 4 fields of inquiry is discovery science, which is kind of your lab-based biospecimen work. Then we've got the clinical trials, health services research, so very much around data and how we use data. And then we've got continuous improvement, implementation science as well. And implementation science, for me, is a really massive opportunity for health, because what's the drivers for implementation? Is it an obligation, or is it evidence-based? And so, yeah, what we've got to present today really does cover, I think, the implementation, improvement, as well as the health services research. And so the vision is to strengthen research culture and inquiry in a health service, improve research capacity within Sarlan and through partnerships, and then establish facilities that integrate research and improvement science, improve access to the best evidence and research to improve health and wellbeing outcomes for our patients. So that's the research context. Now I'll let Tom go through some of the safety and quality aspects.
All righty. Thank you, everyone, for joining online. So I guess setting a bit of the scene about how we run governance in Sarlan. When COVID hit us way back in 2020, we created a number of teams to help, and governance structures to help manage whatever we were going to do safely and in the best interests of our clients and all of our other responsibilities. So I was linked into the establishment of the frameworks of how Salin would do. And I was part of the team to put a bit of a risk lens and to make sure we were providing safe quality care. So it was really good to have clinical governance involved in setting up the COVID testing clinic. And Salin uses a governance framework of an integrated management system where we encourage our clinicians from the front line to either own, resolve or escalate issues. The main sort of, it's a bit jargonish, but essentially it means that what a midwife on the floor reports in their daily huddle, if it's a big enough problem, it can get its way all the way to the board and vice versa. So the ward to board communication is really important and is really embedded in our team. So I'll keep going. So setting the scene. So on the 9th of March 2020, we didn't have a COVID testing clinic. And on the 10th of March, which happened to be a Sunday of a long weekend, we opened one, and we opened a COVID testing clinic in our essentially our vaccine, where we gave our flu shots to staff, which was probably about the size of this office. And we saw 75 patients on day one with variable, it was an evolving structure. So we saw our numbers peak and trough throughout until it was just a big peak. So we eventually moved out of that clinic quite quickly into our decommissioned hydrotherapy pool, where we set up a COVID testing clinic where the numbers ranged from 30 to a day to, I think on our biggest day, we hit 400. So I guess this asked the question was asked really early, was how can we do the registration better? And it was actually one of the first times I've been involved where the Office of Research has come to us and actually come to us and said, the Royal Melbourne have just released some data through the through MJA that they're trialling a self-registration process. And the inquiry was, why can't we do that here? And that was the question. And essentially that was the question that started the snowball. And it turned into a pilot where we tried it at Flinders. So I guess for me, that's probably been one of the real benefits of the pandemic, seeing real-time, like evidence research being done in real time, being published in preprint, and clinicians engaged, clinicians saying, hang on, if Royal Melbourne's doing that, maybe we should be trying, or maybe we could do something similar. So it was pretty exciting. So yeah. So Simon's going to go through the timeline, because I guess the timeline, most people who work in health, the wheels in health turn slowly, and to get something from an idea to a pilot can take quite a long time. But Simon's kind of mapped out the timeline of what happened. So
yeah, and the number to consider with this is 195 hours in sort of, Monday to Friday business time. So we can say that on the 11th of March, the World Health Organization declared a global pandemic. And then at 9:17 on the 19th of March, Di Taylor circulated the preprint publication that I've got up there, looking at early clinical response to high consequence infectious disease outbreak insights from COVID-19. And so that's where we can start the stopwatch there on the 195 hours. And so that's when we sort of reached out to our partners at Royal Melbourne to look at what this program looks like. My team, we were very familiar at that point around, QR codes as an interface opportunity. So we worked up a prototype of what that would look like here in the FMC COVID clinic. Then 5 days later, we presented to Digital Health SA and Salon executive formally were engaged in the process. The Flinders University, our sort of partner, local partner, who had the interface that we worked with, they hosted this electronic registration portal. That was on the 27th of March. Then we looked at the structure and making, and this is where Tom sort of heavily developed it on the floor, the data fields that were relevant in our context. And we also got the appropriate endorsements and authorizations we required. While we were doing that, Tom was seeking consumer feedback as well. So we integrated that into the data fields as well. And that's when the Southern Adelaide Clinical Human Research Ethics Committee approved the program as effectively a health services research registry type initiative where we're integrating into the medical records. And then we got on the 22nd of April with SA Health Electronic Health Systems, the information asset classification, we got that approval there. Then we can stop the watch. 2:05 p.m. on the 24th of April, we had our first member of the public interact and do their self-registration, self-screening at Flinders Medical Centre COVID clinic. And so that was 195 hours from, the initial radar alert to getting it to the public. And that's why I think, it's a really important story to communicate to the Commission as well. So now Tom can take you through some of the key aspects of the rollout.
So I guess the first thing that came to me from a quality and risk perspective was, can we change a system in real time in a system which we didn't actually know? We didn't actually know much about COVID. Well, we knew nothing. When I was reading through my notes to prepare for this was around the time of Ruby Princess. We had the Barossa outbreak. We had, there was all sorts of things going on. We had people being quarantined on Christmas Island, all sorts of things. The next risk we had was, and I'll probably come back to this, is why change a system that wasn't broken? Would our consumers actually like it, and would they use it? A point here I've put in about trust. So within the public health system, I guess the health system more broadly, there'd been a big campaign for the previous 12, 18 months to encourage the community to register on My Health Record. And at that time, within many local health networks, there was a bit of a pushback, a bit of a reluctance to trust the public system with their data. And that was, and when the COVID Safe Act came, that didn't, I'm not sure if that helped the trust. So I know when I piloted these tools, there were people that were reluctant to use QR codes. They were reluctant to provide their information digitally. So the other big risk we had is that essentially we're a hospital. We're not system engineers. We're not data experts. We didn't have a platform. We didn't have the experience. We had a lot of ideas, and we had a lot of clinicians who dabbled in this space, but this is where we really lent on our partners in the university sector who are used to using secure databases and platforms and interfaces, and the Office of the Chief OCMIO. So we really did rely on them, and I don't think we would have got to the pilot had we not had the engagement from them. We had a lot of goodwill, but we didn't necessarily have the system skills to navigate even the ethics side of things. And the thing that was really quite interesting looking back on it is that the rules were changing daily. When I did the pilot, which was on, so I did 2 pilots. The second pilot was 3 days after the first. on the first pilot, we were trying to screen out people. So people without symptoms weren't to get tested. But then on the third pilot, essentially all the questions led to getting a test. So that really changes the way you run a system when you try and set up a process, but it literally is changing. And the other part was, it was a disaster. It was very early on, and it was literally a declared disaster. So it was quite a challenge, but yet we still did it.
The other thing to flag was there was no discrete funding of any sort with this one as well. So there wasn't any special purpose fund or research funding or anything. So that's the other key sort of aspect.
So when we decided to implement, before we went out and purchased too much equipment, we purchased some tablets. We purchased iPads. I'm not sure why that brand, that was just the brand we chose. And we used the REDCaps program, which is a well-regarded, validated tool. And that REDCaps database was authorised by Digital Health under the information asset classification. Essentially, it meant that it was secure to hold data on, which was one of my concerns from a risk perspective. The other big factor is that Flinders Medical Centre had just turned off its old patient administration system and had gone to Sunrise. I'm not sure the timeline there, but it was very new. The computers were all brand new. So that was a challenge. Staff weren't familiar with that either. And we were rolling out this COVID model of care, which we didn't really know, which was evolving quite frequently. And as I said before, the evidence base is still changing pretty rapidly. And it's quite exciting to see real-time evidence evolved into practice. So before we decided to use consumers' own devices or our devices, there was a lot of quite heated discussion and really rigorous debate about should we go down this path. And I thought it was worth a go because I thought it potentially would reduce cross-contamination, i.e. people touching bits of paper, then passing it to a clerical staff who then passes it to an administrative staff who then maybe passes it to another staff. So we thought it potentially reduces cross-contamination. The other aspect is improved accuracy in registration in terms of when things are typed, it's easier for admin staff to read. And the initial idea that will potentially reduce time in filling out the forms. So I guess our initial inquiry is, can we do this? Led to real collaborations, and it actually led to real time change. And we followed our PDSA cycle of change management, and we learned from a multitude of mistakes, and we kept adapting and refining. And as Simon's touched on, we linked into academia. We had academics at the university who helped us with REDCaps, design the forms, set up the systems. Well, I wouldn't have been able to do it, and I don't think anyone else would have been able to do it. So I guess it's showing that public hospitals and public healthcare systems, that relationships between people who have got expertise. I'd even almost think that in future, maybe the public sector, but that gets a bit more challenging as well. But so yeah, keep going, Simon. So pilot one. So essentially what we did was we piloted it on our device first, which was the iPad, and we tried it with a number of questions. That yielded a lot of really useful data. Some of the things that we learned pretty much immediately was that it took a lot longer than the paper form. People reported a lot of frustration with doing it on their mobile phone. We had quite a lot of information on the question, and our internal processes from getting a person waiting for a COVID test to getting to the nurse at the back of the line to do the swab. We didn't get those processes right. And some of the other stuff that I learned was through talking to the consumers was actually about some of our older people or people within maybe altered vision, struggled reading. And the other big thing is, most people are very familiar with QR codes now, but in 2020, a lot of us didn't know that we had to go to our camera on our phone, click the link when it popped up, and we spent a lot of time showing people how to do this. And people were very worried about where that data was going. So I did have to spend a lot of time to say we had a governance structure and that the data was secure. There was a lot of hesitation and trust. And I also think that reflects that staff and clinicians, staff and patients were pretty scared. COVID was it was rapidly exploding. This was probably 3 weeks before it really hit Victoria hard. And so there was lots of media, lots of scare. So it was a challenge. So pilot 2, we took that feedback and we tried to cut out as many questions as we could. We reduced the questions as much as we could, but we still needed to collect a lot of baseline demographic data. We spent a lot of time with the staff to improve the flows, and we improved our posters for the patients in the line. And the fact that it took longer to fill in, unfortunately, the lines were quite long. So it gave people something, people in the line could do this. So we did 18 successful patients who did it well. I learned, again, we would have done more pilots, but I had a person who came with their carer who had a cognitive impairment, and that raised more questions about how do we do self-registration for someone presenting with a carer or a family member. And we had a couple of people who didn't speak English as a first language. So they were just some more challenges. So I guess implementing change management can be a challenge at the best of times, and it's important to do it systematically and pretty methodically. That's the word I'm looking for. But then you throw in a declaration of a disaster and a lot of fear and a lot of change. The other element to it was at this stage of the pandemic, all the LHNs in South Australia were sort of doing their own thing. The system that we have now is very much centralised through SA pathology. And at the time, particularly in Metro Adelaide, all the LHNs were doing their own version of a testing clinic. So the other challenge we had was that at this stage, it was easy for people on brand names such as Apple and Samsung, but some of the other brands, the QR code, we had challenges with. We had a lot of trouble for patients in the line understanding what QR even meant. People were downloading apps, thinking they needed to download apps. And and that was part of us providing better, improved health and digital literacy. I've spoken about people with visual impairments or cognitive impairments. The challenge for staff using a tablet was gloves, gowns, masks, visors. It gets hard to read the user gloves, but I'm noticing that I've been through the drive-through testing clinics that it seems that clinicians and nurses and health practitioners kind of mastered that now. The other challenge we had is where our patients lined up was outside and the lighting was really poor. So there was a lot of challenges. And the other challenge is it was a hybrid system. Even though we were using red caps, it didn't speak to our EMR. So it was still relying on multiple steps. So we followed up. So when a patient did their self-registration, they would record their email address and they would get an email address with their details and registration, plus the relevant federal government COVID advice at the time, which was actually good for us in terms of we were having to provide lots of paper, but the directives from federal and state government was changing literally sometimes twice in a day. So having it as a PDF in the email was quite handy. So we demonstrated that it definitely could have worked, but it needed more testing, more time, and more refinement. So based on the feedback from consumers and clinicians, the other thing I'll chuck in about the clinicians is that at this stage of the pandemic, all elective surgery, I think, was about to be cancelled. So the staff that were working in our COVID clinic were in our casual pool. And so they were potentially worried about losing employment. So there was a lot of pushback from clinicians on the floor, worried that we were developing a tool to replace them, which it wasn't the intention. It was to streamline the process and make it easier, but it did impact the feedback I got. So I guess at the end of the day, based on all the feedback and challenges, although we did decide to stop pursuing this, we think it is still something that should be explored in the future, obviously not with COVID. And as many of you would have seen who've gone through COVID testing clinics in recent months, is that SA Pathology have been able to streamline that service now to Medicare number, name, age, date of birth, mobile phone number, whereas we had to ask, I think, double questions because we're a hospital. So SA Pathology have really streamlined that service. But I guess the take-home message for me is that I think whether it's the public health system or the private health system, using a self-registration system, either via organisations' iPads or devices or via the bring your own device, I think is something we should explore. So, yeah.
Fantastic. So that's everything. Thank you very much for the opportunity to talk to you all today.
Thank you so much, Simon and Tom. What a fantastic story to share, and what a fantastic experience against huge adversity, I think. I remember back in March 15th, I think, in 2020, I was at the Fringe closing event. And so 4 days later, you were off and running with your approach and implementation. So I think that's a fantastic story.